Welcome to Derm-It Trotter, Don't Swear About Skincare, where host Dr. Shannon C. Trotter, a board-certified dermatologist, sits down with fellow dermatologists and skincare experts to separate fact from fiction and simplify skincare. Let's get started.
Welcome to the Derm-It Trotter, Don't Swear About Skincare podcast. Today, we're going to maybe change that byline. I usually say, don't swear about skincare, but now we're sort of shifting to this, don't swear about healthcare, because we're diving in a little bit more into the issues that affect all of us across the healthcare spectrum. I have two great guests on today to actually talk about that, and more particularly Medicare. A lot of you might be wondering, well, what even the heck is Medicare? I'm not even on it, but maybe one day you will be if it's still even here. But I have two guests, Dr. Brad Glick. He's a board-certified dermatologist and dermatologic surgeon with clinical and academic practices in Margate and Wellington, Florida. He's also a member of the board of directors of the American Academy of Dermatology, principal investigator for GSI Clinical Research, and also the program director for dermatology residency program located at Larkin Health System in Miami, Florida. I also have with me here today Dr. Andrew Weinstein. He's a board-certified dermatologist as well, and the managing partner of Skincare Physicians in Boynton Beach, Florida. After serving on the AD Board of Directors, he turned his attention to the broken Medicare physician fee schedule. He's actually chair of the ad hoc task force finding common sense Medicare legislation and has mapped a clear path to stopping Medicare cuts, which we're all very excited about. But for those of you out there, our patients, you're probably wondering, well, why should this even matter to me? But things about Medicare, they might excite you, but they also might scare you. But first, I'd like to open it up to my guests today to talk a little bit about, well, what even is Medicare and why was it created? And how is it different from a word that might sound similar to some of you out there, Medicaid? So I don't know, Andy or Brad, which one of you wants to take that? But thank you for coming on, and let's start off the podcast with that today.
Okay, Shannon, I'll tackle that one, and I'll let Brad talk a little bit about Medicaid. So let me just introduce you to Medicare. Um, First of all, if you don't know about Medicare, it still knows about you. So Medicare is an important federal insurance program that's essentially for the elderly. So you become eligible for Medicare when you're at retirement age. There are some people who are eligible because of end-stage renal disease or for other reasons, but mostly you need to think about it as an insurance program that's sponsored and carried out by the federal government for the elderly in the United States. But it's got a much farther reach than that. So if you have commercial insurance, if you have somebody else that pays for your health care in this country, the amount that is paid, the reimbursement that is given to hospitals, to pharmaceutical companies, to drugstores, and importantly to your doctor is set by something called the Medicare Physician Fee Schedule. And I'm very excited about Medicare because I'm about the same age as Medicare. Medicare first started in 1965, in late 1965, and then the next year I came about. So here we are. We are 59 years, 60 years into the Medicare experiment. And like you said, if we're not careful, that experiment may be over.
Well, that's scary. So we probably just scared everyone there. But Brad, you mentioned the Medicaid piece. So, for people that kind of confuse the two, because I see this even with healthcare professionals, but obviously in the public, they're like, what am I on? Medicare, Medicaid? What's the difference? What is the Medicaid program system?
Yeah, Medicaid is kind of a joint. It's federal. It's also state. Obviously, throughout the United States, it's a form of health coverage that really is more for individuals of low income, individuals and families. It is linked to a number of private payers as well, too. We have a lot of them in Florida, the sort of called Medicaid health maintenance organizations. And it's really to help a specific population of individuals who, for instance, unlike our Medicare recipients, who in our payroll, in our checks that we're receiving throughout our lives, we're getting contributions to the Medicare program specifically. And this is really established differently, both federally and also in the state, to really target a specific population of individuals. It's funded by both, state and federal, and it varies from state to state as well. And I think the idea behind Medicaid at whatever level, whether it is straight Medicaid like we have here in Florida, or the Medicaid managed care plans, the so-called Medicaid HMOs, it's really more for vulnerable populations, I think is probably the best way to explain it. And so, there's the good which is the populations that we're reaching, and then the challenge, because the challenge is, just like Dr. Weinstein said, many of these governmental programs are really based on federal funding. And at the end of the day, at least through my lenses, is one of the things as we see is healthcare seems to be cut at the end. And the chunk of the dollars that are available to go to healthcare seem to be chiseled out at the very end. And really, that's really the crux of the problem. You know, Dr. Weinstein, I'll just put him on the spot here. He really is an expert in this topic and explains it very well. And when we lobby on Capitol Hill, as we do every year at the Legislative Conference, American Academy of Dermatology, and now we have this singular ask because of someone like Dr. Weinstein, who believes, and I do too, that this is critically important for how we get paid. This is what we've been discussing on Capitol Hill, and it's been a part of the challenge that we've been facing, not just this last year, not this last 2 years, but for 24 years since 2001.
Hey Shannon, Brad just said something really important.
Mhm.
Maybe we overlooked it, but he said that when you get your paycheck, a certain amount gets taken out.
Yes.
And so what that means is that all of the seniors who are in Medicare right now, it's not a welfare program, it's something that they paid for. So they
Mhm.
paid for Medicare, and in 1965, when Congress created the Medicare program, they made a promise to our seniors. And that promise was that healthcare was going to be there for them, and our seniors paid for it. And there's a cynical game going on in Congress right now where every year since the inception of the way we pay for Medicare, every year we seem to get a cut. And certainly, this is an amazing fact. I graduated from medical school in 1998. That year, what's called the conversion factor, and that is the amount that's reimbursed for Medicare, was higher than it is today. And you can't sustain a system. So imagine you sold hammers. Imagine that you had to sell a hammer in 2025 for less than you did in 1998. That doesn't work out for these offices, for offices like mine that provide services for Medicare recipients and for others. And we front the cost of that. The government is supposed to pay it back, and they have just not been doing that. That's bad enough. But that fee schedule that they use, and it's really based on the resources required to deliver a service. That fee schedule that they use is used by every other insurance company. That's why if Medicare goes down, your insurance goes down. Now, your cost of your insurance doesn't go down, the benefits go down. And that's what we've been facing. We've been facing a Congress that refuses to face its responsibility, that refuses to keep its promise to the elderly, and they've already paid for that Medicare.
That's a great point you bring up because I'm sure there are listeners out there like myself that's wondering, well, what does this matter to me right now? They're thinking, I'm not going to be eligible for Medicare for quite a while. I might be paying into it, but again, oh yeah, it's going to be there. I think there's this false sense of security. And like you mentioned, though, the impact on kind of how that affects their benefits or my benefits, even having commercial insurance, where I'm at right now in life. That's where I think it's important you really highlight that for people to understand it affects us all. It's not just, our grandparents that you might be thinking of that might be on Medicare, but it affects us, as a country and as a healthcare system. If you think about Medicare, though, for people just trying to get, I don't really understand what it is, or I've heard of A, B, C, D, E, F, G, the different parts of Medicare. How would you briefly kind of explain that so people understand the different parts of the Medicare plan, if you will?
Well, I can jump in. There's the Medicare Part A is more hospital based. And when you're in the hospital, that's the part that's covered in the hospital. Fairly sure that that is accurate. Part B is the more ambulatory component. D tends to relate to matters that are a little bit different than hospital and outpatient. It's more related to, let's say, therapeutics like drugs, devices that need to be performed where there needs to be covered in a different vehicle. Andy, you want to add to that?
Sure, I'd be delighted to expand on that. So it's interesting. Remember that Medicare was envisioned in 1965 when people would go to the doctor and they would pay their doctors, and they would go to the hospital and they would pay the hospitals. Each of those had a different, really was thought to be very different in people's minds. So as Brad said, they made Part A, and there's a premium for Part A. The premium is paid through your paycheck, and then there's a premium for Part B, which is paid through your paycheck, and then an additional premium that you have to pay when you want to use it. So A is for hospitalization, B is for physician services, and then in 2006 they developed Medicare Part D for drugs, and that's an additional premium that you pay. And that's the part that this year in 2025 they capped out at $2,000. So your maximum out of pocket payment is $2,000 in 2025. So that's your Part D. And many of you have probably heard of Medicare Advantage. Sometimes we refer to Medicare Advantage as Part C. Medicare Advantage is a program where the Medicare system pays a certain amount to an insurance company, whether it's Aetna, Humana, all of the companies do it because it's extraordinarily profitable for them. They pay them a certain amount, and for that private company insures the lives of patients. And they're entitled to bonuses above what they've been paid. And so they've been criticized for that. So they've been criticized because Medicare Part C, or the Medicare Advantage programs, seems to always be accused of having excess payments applied. And they have an amazing lobbying department, an amazing advocacy department that seems to always make sure that Medicare Part C gets increases, even though they're accused of being quite wasteful. So that's what you have. You have A, hospitalization, B for your doctor's office, D is for drugs, and C is the non-traditional Medicare Advantage programs.
So now that we have kind of a better understanding of sort of what Medicare is, so people kind of out there get an idea of the different types or, parts of Medicare. One of the things I have patients come in, they're like, I don't understand why, doctors in particular are frustrated with Medicare. I think patients know. I mean, they get frustrated maybe with coverage issues, but how would you explain it, why doctors might be getting upset with the Medicare system and what's happening?
Yeah, I referred a little bit to this before, but let me just say my concern is not that the Medicare program will go insolvent. It's that doctors will stop taking Medicare, and that's worse than it going insolvent. So the real frustration is that cynicism that Congress views Medicare with. So as I said, the Medicare system is designed to be inflation sensitive because if you take Medicare, you're not allowed to set the prices. When you go to McDonald's now as compared to 2001, things are 20 or 30% more. When things are more in our offices, when wage inflation hits doctors' offices, or when supplies increase, we had dramatic increases in our supply costs during COVID. And as a matter of fact, this year it's estimated that our supply costs are going to be up at least 3.5%, if not 4%. When reimbursement goes down during those same periods of time, doctors get frustrated and even though they want to take care of those patients, they sometimes can't. They have to do things that allow them to raise their prices, and taking Medicare is not one of those things. And it's a real conflict for a lot of doctors because we all want to take Medicare. We want to keep that promise that Congress made, but the reimbursement just has to be what the cost of delivering those services is.
Yeah, I couldn't agree more. And, I want to share a story. I think that's really the best thing to do. And I can share some patient stories too, but I want to tell you about a car ride that I was taking with a colleague of mine. For the last 4 or 5 years, I kind of had my head in the sand. I'm a dermatologist. I have a successful practice. Seemingly, I have a successful practice. I don't know, maybe I wasn't looking at my expenses just so carefully. Maybe I don't look at my explanation of benefits that carefully. So I'm riding in the car with a colleague of mine who runs a practice very much like mine. And as I'm talking to him, he said to me, Brad, my walls are kind of crumbling a little bit. I'm nervous. I'm not sure that I can keep doing it. Myself and my 3 other partners, I don't know that I can keep doing it because my expenses has exploded. The salaries of my staff members have gone up exponentially. Oh, we used to have front staff that made $12, $13, $14 an hour. Everyone makes $20 an hour now or more, or 25 or more. It's expensive. That colleague I was riding in a car with was Andrew Weinstein. And I learned a lot from that conversation because that conversation turned me around to kind of look at what was really going on in my practice. Because it looks really good. I have my own building. I see patients every day, lots of patients. But then when you start to look carefully, we're seeing patients for cut rate reimbursement. The Medicare reimbursement is down if we look at it against inflation, because if you look at the graph just keeps going up on inflation. You look at that Medicare economic index, but our reimbursement is not only flat. If you look at the last 4 years, it's sinking down. I would ask a simple question to both of you. Who runs an organization, a business this way? And I hate to use the word business because my patients don't necessarily want to hear it, but we are running a business. We have to pay for things just like a pizza place does, a restaurant does, all the malls and the different businesses. And so I bring up this story because it opened my eyes. And I thank Andy about that because I'm concerned now too. I'm mindful about how I'm running my clinic now. And so we're feeling this pain. We really are. And so are our patients.
You know, a lot of us have experienced our favorite restaurant closing, and you know what happened before that restaurant closed? They were doing fine. They had customers, but the owner closed the books one day, and the amount that he or she brought in was less than what it cost to run that restaurant. And the next month, that restaurant closed. And the same thing can happen in doctors' offices, will happen in doctors' offices. But I'll say this about dermatologists, about us. We have other options, and that's one of the problems. So many of our colleagues want to take care of Medicare patients, but they do other things. There's cosmetic procedures, there's cash pay, there are lots of things, and that's frustrating to patients. But the bottom line is, Shannon, that the month that we close our books and we have to write a check to support that office, it's likely that dermatologists, that any physician won't do that anymore. And that's very much reflected in the crisis around finding a primary care physician. That's why most of them in this area anyway charge a very large sum, thousands of dollars, for a subscription to see them, this so-called concierge medicine.
And I think that's where, it may scare people. I think, first of all, what's important to, point out too is that, some patients and people listening might think, oh, well, Medicare cuts, don't doctors already make, plenty of money, and, doctors do okay financially. I think they forget, like you mentioned, the reality is it is a business, and you do have to pay all your employees. You have to pay the utilities. You have to do all these things. And if you're not making that money to just simply afford to run a business, that's where you make tough decisions. And I think highlighting that again, or pointing that out, of how you said simply, some doctors just may choose not to take Medicare because it just can't help support, their practice, to keep up, from a business standpoint. That's a hard reality. I think emphasizing that patients get that. And it's not that doctors want to do that. It's that they're just in no other position, or like you said, they have options. I think, probably more popular where you're at in Florida, maybe, than other areas, but I've seen it up here too, where docs have said, forget Medicare, forget insurance. I'm simply going to have you pay, that monthly subscription and come see me. But that's not doable, for the average patient. And frankly, not that we want to get an argument of fairness. It simply just isn't fair for the people that paid into the Medicare system and expected this to be here. So for patients to get an understanding of that, I think that's what I don't want them to think, because I don't want this kind of approach that people think that, we're not trying to necessarily get more money per se, because people are trying to get wealthier. We're trying to get reimbursement that's reasonable to keep the practice or the business of medicine, alive, so we can continue to care for Medicare patients. Because I think that's an important message that we emphasize. Would you not agree?
No, I completely agree. That is so well stated. And this isn't really about me, money that Brad gets or Andrew gets. It's for the practice, for our patients, number one. And in order for us to be able to care for our patients, we have to pay our bills. We have to pay our staff members. I've had to make some decisions this last couple of years in terms of how we structure the number of staff members we have in the clinic. The expenses have gone up. If I take away one individual because of various decision making that I have to make within my practice, in my opinion, that affects access to care. And it's all about the access to care, Shannon. I mean, the example of concierge medicine, VIP practices, or dermatologists just taking cash-only practices, and it's happening. It may not be 20%, it may not be even 10%, but it's rising. Dr. Weinstein and I have many colleagues that are starting to do this, particularly as they're getting mid-range in their career because they're frustrated. And here's the biggest problem in that dynamic. If someone doesn't take Medicare, or if they take cash only, those doors are closed. Here in South Florida, those patients who have skin cancer, what is the cash paying physician going to do? They're going to see a patient with a skin cancer who's not willing to pay cash, who really wants their coverage to be through their health plan, it's going to block the access to our seniors here in South Florida who really need the care that they deserve.
Yeah, there's two sides to it, right? That no physician is going to close his or her office if a bundle of money's coming in. That's not what's happening. Offices are literally closing because the cost to run that practice is more than they bring in that month. So we're really there. It gets to this idea. It's kind of an esoteric concept in economics and business called the margin. And as you get closer to the margin, your ability, you could be your margin could be 5 or 10%, and you could be doing fine. You're doing fine. You're paying all your bills. You're taking home a nice paycheck. And when the next month you're so close to that margin, it's zero. So the difference between surviving, it's like Walmart. Walmart, I don't know what their margin is, like 2 or 3%, but it's hundreds of billions of dollars. I'm probably exaggerating that, but it's okay until they cross over that margin, and that's when Walmart stops selling things. And that's really where we are. So we're close to the margin. So we do things like we try to cut services. So in my office, when you call the office, somebody answers the phone. People appreciate that. It provides good continuity of care. Those are things that have to go by the wayside. We help our patients get medications. We will not be able to afford to do that because that extra employee might push us over the edge. And in reality, the reason why I consider it so cynical is that Congress knows that the amount that of office is reimbursed is not physician salary, not at all. It's for the real resources that are associated with delivering that healthcare service. And most of it is the cost of table paper and supplies and your employees and all the things you need to do. So not reimbursing you for that is cynical because we are not permitted. When you take Medicare, you're not permitted to charge what you want. The market forces don't apply. So we need to do something right now. We need to make sure that seniors know that their Medicare benefits are in jeopardy, that it's a real threat. And I think that if they knew that, I think that they would be on the phone right away with their congressmen, their congresswomen, and their senators. And they would say, it's time for you to stop cutting Medicare because this year alone, Congress failed to intervene when Medicare was cut by 2.8%. That might not seem like a lot, but that is what accounts for essentially us being 75% down. Again, since 1998, costs are up by somewhere between 75 and 100%, and our reimbursement's down. That is not a formula for me to take care of somebody's grandmother.
And you just touched upon this, Andy, in the last couple minutes here. What can patients do? Because a lot of patients probably listening, the public out there, and even healthcare providers that listen to our podcast, they're probably some of them in the dark. I mean, they may not own their own practice. They may not be aware of this. They might be a little bit kind of, oh, I read an article about it. Or some patients out there, people listening might say, yeah, I think my grandmother no longer can see her family doc because they're not taking Medicare any longer. But what tangibly can they do? And you touched upon that with making phone calls. Is there anything else that we can empower people do to help with this?
Yeah, I want to jump in here just as a general first comment is that that's the whole issue because even organizations, whether it's the AMA, the AOA, even our American Academy of Dermatology, we lobby on Capitol Hill. We try to do all the right things to make our voices be heard, but that's part of the problem, Shannon. You just basically said it. We have to have Congress hear our patient voices. And so how do we accomplish that? Picking up the phone and calling the senator's office, whether it's in the state or it's federal, was very difficult. One of the ways that we've done this, and it's somewhat effective, is, QR codes, links that patients can directly write their own letter. There's crafted letters on their behalf. That's how we start. But I think there's a bigger picture here. And the bigger picture is that we need to put our patients on stage. The Congress needs to hear the voices of our patients live and in person. They need to see it from the overpasses of highways with posters that basically say, I can't get into my doctor's office because there's an obstruction to care because the walls are crumbling inside the office because the three people that used to be at the front, Dr. Glick and Dr. Weinstein, can't really afford to keep three people, maybe two, maybe only one, because the cost to run our practices have gone up so much. So we're being a little redundant, but on the reverse side of it, we have to hear this from our patients. They have to tell the stories about how it's impacting them. Andy, your thoughts?
Yeah, I think that the answer is patience. I have a slightly different take on this, if I can share it with you, and that is, if we were running a business, if we were the Better Medicare Alliance, who represents Medicare Advantage, and we came back to the Medicare Advantage programs and said, guys, I'm sorry, there's an assault. You guys are going to get a 2.8% cut. That group would be fired immediately. So this is not an option, and I think that our organizations need to do better. I think that they need to accept the idea that 25 years of data points of falling Medicare reimbursement is enough to say there's something faulty with the processes that we use. And so I think that we need to change them, and it's obvious. So I think the first thing we need to do, I think this is a House of Medicine problem, but I have not heard one organization offer up really innovative ideas to change things that match successful lobbying campaigns, which have happened. So here's what I think. We're dermatologists. We are members of the American Academy of Dermatology. I think members need to speak up. They need to let our leadership know in the American Academy of Dermatology that we demand something different. We know that the DC fly-ins, the polite visits to congressmen's offices, the PAC checks that get lost in the political machine, they are no longer acceptable to us. We need seniors to see this. So we need social media. We need standard television. We need to get them excited to the point where they understand that they're about to lose their Medicare, and they do make those phone calls. I think the robo letters don't work very well because I think that Congress is not really concerned. But hanging signs from bridges, Brad, that's a real one. So why do we have organizations? They do things that we can't do alone. They provide fellowship. They provide education. And if the three of us on this meeting today could organize all of this, we would. But large organizations can, and we should demand that. I say we start by getting rid of that idea that we are talking about physician reimbursement, because we're not. We're talking about stabilizing the Medicare program against cuts. I say that we empower, we require, we enable the staff members of all of these organizations to come up with ideas that work, not ones that are, there's no participation trophies. So, I do have a list of things, through my committee that I've developed, and I will be presenting that, and I hope to find a real paradigm shift with it. And I know that's a hackneyed phrase, a real paradigm shift within the American Academy of Dermatology, where we have some demonstration projects, where we have more effective political giving, where we only support candidates who understand how important this is for seniors, that we enable innovation. And once we do that, I think the House of Medicine will see the example, and I think that we can solve this, but it's not going to be by doing things the same way.
And the important thing is we're doing all this for patients, and I think that's
That's
the
right.
priority. Keep that, as our, focus, and, let people know out there that this is really physicians fighting for you, where I think, sometimes, like you said, it gets reframed on this reimbursement piece. And no, this is the ability to keep a business open, to provide you with the best care possible. And this is to keep Medicare sustainable for, future generations as well, where it'll hopefully be there for them in the future. But thank you both for coming on the podcast today. I can't believe our time's already flown by. I think we've, really probably gotten a little bit enlightenment for people on what Medicare is, the impact, and then truly people understanding why, Medicare is truly in crisis, and how this impacts, everyone, but in particularly, again, patients. And so again, thank you both for coming on the podcast. It's been a lot of fun to have you here with us today. If any of our listeners want to find you or connect with you, please feel free, go ahead and share, if you don't mind, Andy, and then Brad, if you'll share your social media or online presence, that would be great.
Sure. I'm at Dr. Andy Weinstein on Instagram. And you can, of course, visit my website. It's Andy for the number 4 AADPres.com.
And mine's pretty simple. It's at Brad Peter Glick on Instagram.
Great. Well, thank you guys again, and stay tuned for the next episode of Derm-It Trotter. Don't swear about skincare, or maybe, as we've done today, don't swear about healthcare, as we really dive in a bit more into healthcare issues that affect us all.
Thanks, Shannon.
Thank you.
Thanks for listening to Derm-It Trotter. For more about skincare, visit dermittrotter.com. Don't forget to subscribe, leave a review, and share this podcast with anyone who needs a little skincare sanity. Until next time, stay skin smart.